In this presentation, I will be focusing on why symptom screening and distress screening are important, up-to-date evidence of impact on cancer care processes, symptom prevalence, and severity. The presentation today will focus on the clinical issues addressed by symptom screening, the evidence for symptom screening, particularly focusing on is it worth it? And then I will conclude with an overview of a provincial project to increase the spread and scale up of symptom screening in the province called eImpact. So we know that patients' symptom burden is underestimated in clinical practice. Healthcare providers report lower percentages of moderate or severe symptoms, more so than patients. Underestimation of a patient's symptom is more common than overestimation. The highest level of agreement among patient and clinicians in terms of severity is among symptoms such as pain, vomiting, and diarrhea, albeit that the agreement is still low. But lowest levels of agreements have been noted for more, I guess we could think of those as more subjective symptoms, such as fatigue, anorexia maybe, and constipation. And there are a number of factors that have been associated with underestimation, such as a poor Karnofsky score, better scores on Mini-Mental, recent cancer diagnosis, and also opioids still being titrated. Other studies than the one on the slide here have also shown that sometimes lower age of the patient has also been associated with an underestimation. In this slide, the graph that you see, the orange line represents what patients report in terms of the severity of their symptoms. The blue line is what clinicians have reported. And this study further corroborates what was presented on the previous slide in terms of the gap for the severity reported by patients and their clinicians. And we can see that for, again, some symptoms, it is more so than others, particularly those subjective symptoms that we saw in the previous slide, such as fatigue, anorexia, and here I guess we can also add nausea. So underestimation of patients' experience of their symptom severity might lead to preventable morbidity, which is costly, not only to the patient in terms of their quality of life, but also to the healthcare system. These patients we know are higher users of healthcare services, including physicians, but also the emergency room department. So this is the clinical challenge that we are faced with. What are potential solution, or what is a potential solution? One that is most documented in the literature and has a lot of evidence to back it up is to get the information directly from patients, which is referred to as patient-reported outcomes, or PROs. PROs are a measurement based on a report that comes directly from the patient about the status of their condition without amendment or interpretation of the patient's response by a clinician or anyone else. PRO data often include quality of life, physical symptoms such as pain, fatigue, psychological symptoms such as distress or anxiety. PROs are typically collected using validated questionnaire, and you have one here, such as the Edmonton Symptom Assessment Symptom System. It's probably, or the ESAS. The ESAS is probably the most widely used PRO measure in the province, but also nationally and internationally. You might have heard of others, such as the distress thermometer. There's also the PROMIS system. More recently, there's the PRO CTCA. So these are all PRO measures. So what is the evidence? Is it worth it of investing in integrating PRO screening programs in your clinical practice? Well, according to many systematic reviews and meta-analyses, and these just keep on being published, the answer would be yes. But it depends what you're hoping to achieve. If you're hoping to achieve improved patient-provider communication and patient satisfaction, we have very strong, consistent evidence to support that using PROS will have an impact. There's moderate evidence to show that collecting of PROS is generally associated with improved symptom management, including early detection and monitoring of symptoms and symptom-related actions then by clinicians, which in turn can reduce symptom prevalence and severity. The evidence is slightly weaker. This only means that there's mixed findings in terms of whether these more proximal impact of improved communication, improved symptom management will then have an impact on patient outcomes, more distal outcomes, such as quality of life. But several studies do show that this will, that PROS screening still has an impact on quality of life. And then it's not that that PROS screening doesn't have an impact on broader healthcare systems outcomes, such as healthcare service utilization. It's just that the evidence is minimal, but emerging. And I think one major barrier in terms of integrating PROS screening, or at least electronic PROS screening, is then the integration with the electronic medical record. PROS screening is extremely popular throughout worldwide, and the evidence base for using this in clinical care is increasing every day or every week. There's a new study that has come out to demonstrate impact. One of the most seminal studies that you might have heard of is the BASH study at Memorial Sloan Kettering among 766 patients receiving chemotherapy for a metastatic solid tumor. And they were screened using a web-based screening monitoring program and with alerts being sent to the nurses if symptoms were severe. So what we saw is that there was improved quality of life, reduced emergency room visits for those that were screened. And the reason why this study is so widely cited is because they also showed an increase in survival among those that were screened. So median overall survival of 7 years. At the 7-year follow-up, median overall survival was 5 months longer in those being screened. Similarly, in France, among patients with lung cancer, they looked at routine versus weekly web-based symptom screening, again with an alert to the oncologist. And they actually closed the trial early because of the noted survival, increased survival in the PROS screening group. So not all PROS screening programs are created equal. Throughout the literature and throughout the different studies, we have now identified key components. The one component is the regular systematic screening. So you saw in the previous studies, that screening was done weekly. Often we say that screening can be done at each transition point. I think clinically that makes sense, but right now the evidence doesn't support that. It seems that the more regular that you screen, more likely are you to able to to achieve the outcomes previously stated, or the benefits. Screening on its own is not sufficient. Then the PRO data need to be fed back to clinicians in actionable format, and not only cross-sectional data, but also longitudinal trends. Alerts seem to be key. So we saw that from the previous 2 studies, that alerts were sent to a key clinician. and also having follow-up care available. This doesn't mean referrals. This could be access to high quality education materials, maybe community-based services, depending on your area. So using PROS doesn't mean work more, but it means working differently. It's really about increasing efficiency by using the PRO data that is available during the consultations. And there are many studies that have shown that actually what happens when you have PRO data available is that the consultation and the discussion becomes more focused, which in turn can help you save time. Also, having different standardized algorithms for screening and treatment referral pathways can reduce variations in care. So the results to date are quite compelling to use PROS in clinical practice, but a lot of these previous studies are from randomized controlled trials. So what happens when we try to implement these results in real world settings where we know it's quite messy, complex, it's not as sterile as a randomized controlled trial? The evidence that we have to date comes from Ontario. In this province, ESAS has been used for routine screening since 2007. So they're starting to look at what are the impact of screening in the province. So what they're seeing is that among women with breast cancer that were screened for ESAS, fewer emergency department visits are noted than those that were not screened. So this is the solid line where represents emergency room visits among those that were screened, and then the dotted line among those that were not screened with the ESAS. Similarly, they are replicating some of the data regarding mortality and survival. So ESAS assessment was significantly associated with a decreased mortality risk. So even in real world settings, we're seeing that some of the randomized controlled trial results are being replicated, which is very encouraging. So what are we doing in Quebec? In 2011, the PQC released recommendation for distress screening based on ESAS and the distress thermometer. I would say then this was followed by years of different centers implementing mostly pen and paper screening programs. In 2015, there was the first electronic ePRO program called IPHOC, with leadership in Ontario, but 3 centers in Quebec did participate. And this was actually the first initiative to implement the same electronic PRO screening programs across 3 centers. Then in 2017, CPAC, the Canadian Partnership Against Cancer, recognizing the evidence for PROS, launched a pan-Canadian funding opportunity to implement PROS in cancer care. And this is where EMPAC was launched. So the objective of EMPAC is large-scale deployment of a symptom screening and management program for cancer patients and their caregivers using electronic platforms. We are focusing on using electronic platforms because we know that these can facilitate patient screening because they generally are accepted by patients. They have a versatile use, so you can complete your questionnaires at home before coming in for your appointment. They're very efficient in terms of translating data into usable format. You remember that one of the key components of a PRO program is feeding the information back to the clinicians. So hopefully the electronic platform is able to analyze the data and create reports that are easily understandable. It can create or trigger clinical alerts and also hopefully with time, this is not the case yet, not in the province, to be integrated with electronic medical records. EMPAC is a co-development among 49 clinicians, managers, researchers, patients, and caregivers across 7 cancer centers in Quebec. This slide just presents an overview of some of the key components, and you'll see that it resonates with what I presented earlier, where everything starts when the patient has an appointment, and before that appointment, key questionnaires are triggered and can be completed on patient's phone, tablet, or computer. EMPAC is not an electronic platform. We provide content that can be uploaded to the electronic platform that the cancer center uses. So some of our primary questionnaires include the distress thermometer, the ESAS, the Social Difficulty Index, and the Canadian Problem Checklist. Depending on answers on some of these questions, patients might be given secondary questionnaires. So for example, if the patient responds 2 or more on the depression item of the ESAS, they are then given the PHQ-9 to provide more detailed information to the clinician about the severity of that depression. Then a report is generated with both cross-sectional and longitudinal data. Again, how that report looks depends on the platform that that center uses. On the report, very importantly, symptoms are categorized as mild, moderate, or severe. And based on that severity, then there is a step care model, follow-up care trajectory that is suggested. All of these, though, are grounded on having access to high-quality self-management resources, which are available on our website. And if the patient has 1 severe or 2 moderate symptoms, a clinical alert is generated. And then hopefully over time, some of the reports can be stored in the electronic medical record. So this is a detailed overview of our algorithm for each, and you can see the symptoms that we do screen for are detailed and vary from physical symptoms to more emotional symptoms, psychological, as well as social and practical. So very comprehensive screening. And here we see the symptoms on which, depending on the score on the ESAS, trigger secondary questionnaires. And the depression one here as an example, if the ESAS score is 2 or more, then the PHQ-9 is triggered. So right now, depending on the center,